Thank you. This is really an important topic for all of us, not just here in Auburn. It's an important topic here in Auburn, but it's an important topic everywhere. It's not just a local issue, it's not just a county or a regional issue or a state issue or even a national issue. This is an international crisis, and we can't pretend it doesn't exist. But before we get started tonight with the presentations, I want to give you just a few facts. And this came from the American Society of Addiction Medicine from 2016. Of the 20.5 million Americans 12 years or older that had a substance use disorder in 2016, 2 million had a substance use disorder involving prescription pain relievers, and 591,000 had a substance use disorder involving heroin. Drug overdose is the leading cause of accidental death in the United States, with 52,404 lethal drug overdoses in the year 2016. Of those, 20,101 overdose deaths were related to prescription pain relievers, and 12,990 of those overdose deaths were related to heroin. We have to change that. Opioid addiction did not become a crisis in our communities overnight, and we know that we're not going to resolve it overnight. But I hope that by us working here together today, we are on a path forward where we can begin the road to recovery. We can begin moving forward. So with that, I would like to introduce to you the panel that we have here this evening, and I will start over on your left. Commander Steve Stalker of the Auburn Police Department, and Steve was a member of the King County Heroin and Prescription Opioid Task Force that King County Executive Dow Constantine, Seattle Mayor Ed Murray, Renton Mayor Dennis Law, and myself co-convened about a year and a half ago. So let's give Commander Stalker a round of applause and welcome. And Deputy Chief Kevin Olson from the Valley Regional Fire Authority. Dr. Stephen Anderson, Director of Emergency Medicine at Multicare Auburn Medical Center, and a physician who I admire greatly, and he speaks nationally on this topic. And also we have the Assistant Division Director of King County Department of Community and Human Services Behavioral Health and Recovery Division. How do you get that all on a business card? That's really long. We've got to get you an acronym or something. This is Brad Finegood, and he was one of the co-leaders of that heroin and opioid task force. And is Keith here? Keith is not here yet, but when he gets here, Keith Minnar is an Auburn resident, and he is going to share his story with you about how he became addicted. We had a conversation a couple of months ago. I'll just share a little bit about how we got Keith here. Keith and I have known each other for a long time, and we have children who are about the same age. They're not children any longer. My daughter is 18 and a half, and his son is 19 and a half, so they were a year apart in school. And his son, Bailey, was a star wrestler and also, I believe, played football at Auburn High School. And Keith contacted me a couple of months ago, texted me and said, hey, what are we going to do about this addiction crisis? It's even hit our front door. Now, I will tell you, when he said that, or when he texted that to me, I thought, oh no. Bailey got injured in sports and got addicted to prescription pain pills. So I said, yeah, let's meet, let's talk about it. And so we met, and he goes, well, I'm sure you know what I'm going to tell you. And I thought, yep, I know what you're going to tell me. And then the next words out of his mouth were, I'm an addict. I was speechless. And then he starts to tell me, and I don't want to steal his story, but he starts to tell me about how he, at 40 years of age, got addicted to prescription pain pills. Now, he didn't get them from a doctor, but he got addicted to them. So he's brave enough to share his story with everyone tonight, because he said if it'll make the difference in one person's life, I'm willing to stand up on that stage, really vulnerable, to society and tell my story. So when he gets here, we'll have him invited up to the stage so he can share his story as well. So we know that it hits everybody, and I believe we already had the question, right? Oh, I'm sorry, I did. You know what? Because I don't have you on my list, that's why I didn't. You're a sub. You know what? I am just going to give you the microphone and let you introduce yourself, and how rude of me to forget you.
That's okay. Hi, I'm Rose Baldridge. I am the COD Clinical Services Manager for Valley Cities.
Thank you. And now to get this back in there without turning it off. I did it. Okay, so I believe we already did the first question. Is that right? About how many of you have had this addiction touch your lives? Is that right? Was that the first question? Okay, good. So we know that it can be personally or professionally an impact on our lives. So I am going to turn this over. Do we have the results of that question? Is it possible to get that back up, or am I asking too much? Oh my goodness, 81% of those of you here tonight that took this poll have had an experience or an encounter with addiction. Thank you for your willingness to be honest about that. We appreciate that. And let's get started. I believe we're going to start with Commander Steve Stalker. So I am going to give you, do you want to sit and talk, or do you want to stand and talk? You want to sit? Absolutely. I'm going to bring the microphone over to you.
Thank you, Mayor. Well, good evening. Thank you for coming and taking time out of your evening to come to this important meeting and listen to the folks up here and listen to your police department also speak with you. Back in 2016, as the mayor mentioned, I had the opportunity to be on the task force that was formed in King County, the Opioid Task Force, and to roundtable recommendations on that task force. There was a bunch of amazing people on that task force, a lot of smart people, a lot of people that have been touched by addiction, and many recommendations came out of that task force. The police department, the city of Auburn, agreed with the majority of the recommendations. And the police department here in Auburn is also highly aware of the situation that is occurring in your city and in our city. What is being called an epidemic, the opioid heroin epidemic, and we all see it right now in the city of Auburn. Not just the city of Auburn, South King County, Seattle, you name it, Snohomish County, Pierce County. We see it on a daily basis as you drive down the street. I can tell you that your police department here in Auburn is working extremely hard to continue to work on this problem. This is a daily topic of conversation at our police department. In briefings, in side meetings, we're constantly talking about how what we can do, what our part of the police department can do to try and help solve this problem and help people and get them the help that they need. As you know, officers are tasked with enforcing laws, and that's what they have to do. But our officers are also tasked with being counselors, and that's something that they're doing on a regular basis every day. They're contacting people on the street, and when they have to enforce the law, they do. But that is not the first thing that they try and do when they come across somebody who maybe has an addiction. They try and evaluate that person. They do everything they can to help that person. If they need to enforce the law, then they do. But I can tell you that your police officers here in Auburn are some of the most compassionate people that I know. I see it on a daily basis. One thing that we need for first responders is we need more resources. Some of the recommendations out of the task force were, rehabilitation and prevention. And that's absolutely what needs to be increased in King County is prevention and rehabilitation. For first responders, your police officers, the challenge that we have is we do not have the resources to help these people. Meaning, when we come across somebody who's in need on the street, sometimes we don't have anywhere to take them other than just to the hospital. Sometimes we don't have resources to tell them where to go. It's one thing for an officer to just give a phone number to somebody on the street who's who has an addiction, but what are they going to do with that phone number? Probably nothing. So that's something that we tackle with on a daily and a nightly basis. One of the recommendations of the task force was to have a naloxone program, a Narcan, which is a drug that can help reverse an overdose. Your police department here in Auburn, back in September of 2016, we do now have a naloxone program, and we have naloxone in all the patrol cars and with our officers. Since September of 2016, we've had 14 applications of naloxone. Out of a handful of those 14, there is no doubt that the actions that the officers did saved that person's life. That's an important recommendation from the task force that the majority of King County has accepted and has implemented within the first responders. I also would like to point out that here in Auburn, we just got some results of crime statistics recently, and crime is down in Auburn, pretty significantly in some areas. One of the reasons for that, I believe, is because of the programs and the things that we are doing within the city among the city's administration and the police department. Your police department has amazing police officers. You've probably run into some of them. You've probably run into maybe our bicycle officers or our community response team officers. They're out here on a daily basis doing everything they can to keep your community safe. In closing, what I would like to ask of you is that we need your eyes and your ears. So if you see something going on, we get reports of people shooting up with needles right on the park benches. We need you to call 911 if you see those things. And it's not just so that our officers can respond and arrest that person for having drugs. It's so that our officers can get to that person and maybe get them some resources and get them some help and get them going in the right direction. So please, if you see something going on like that in the city, please call 911. Thank you.
I'd also like to say thank you for showing up tonight. It's important for the communities to come out and address these types of issues. The fire department has been equipped to deal with the opioid issue for a long time, because one of the primary things we do to care for a person who is in an opioid overdose situation is that we make sure that they have a good airway, that their heart is beating, and if their respiratory drive is decreased, we use a bag valve mask to breathe for them. And quite honestly, we can probably breathe for them better than they can breathe for themselves on room air. So when we respond to an opioid overdose, the first thing we do is we address their ABCs, and we specifically address their airway and make sure that we get a bag valve mask on them right away and start breathing for them. So again, like the Auburn Police Department, the VRFA is very active in the community and very concerned about this opioid issue. So we reached out to the county when we had an opportunity to participate in a pilot program last fall. So the VRFA participated with 5 other fire departments in King County to start carrying nasal naloxone. Through the pilot program, we had 5 applications of naloxone that were all very successful. And again, we focus on the airway first and then the naloxone application. Whereas police officers don't have the ability to assist with respirations with a patient, naloxone is very important for them because they can get that application in several minutes before we arrive. But just to give you an idea of how the system works, for years we have been using naloxone with the Medic One program in King County, and we have a tiered response. So as the dispatcher receives a call, BLS is assigned to the call and sent, and then as the dispatcher, the call receiver collects more information and gives it to the dispatcher, it's often upgraded. So in years past, we would arrive and again just focus on the airway, and when the medics arrived, they would give the naloxone to the patient to reverse the opioid issue. So again, from an emergency response standpoint, we've been addressing this issue for a long time because the airway is the key thing, and making sure that they get oxygen. In addition to the opioid pilot program, the naloxone pilot program, we've been participating in a pilot program for the last year and a half, and it's through the county, and it's called, we have community medical technicians. We call it the CMT rig, and we've partnered with the county and South King Fire and Rescue to put this rig in service. So we have 2 firefighters on this apparatus for 12 hours, 365 days a year. And the goal of this apparatus is to address low acuity calls. And I think just to kind of add on to what Commander Stalker was talking about, we really want to find an avenue to connect people with the right type of care. And currently that doesn't really exist in the county. So there is a Medicaid waiver project that is occurring that is hopefully going to provide some funding that will allow us, healthcare in general in the county, to address a lot of issues so that we can communicate all the way from emergency responders, hospitals, and the entire healthcare network. And so we're really trying to address those issues through our community medical technician unit so that we can, when we arrive to those low acuity calls, whether it's a fall patient or someone dealing with a mental illness issue or drug addiction or anything like that, that we have the capabilities to connect those people with the proper care. And that's really important right now to find help for these people that are dealing with these opioid addictions.
Hi, everyone, and thank you all for coming. This is amazing. What a turnout, huh? So I'm from Valley Cities, and I just wanted to share right now Valley Cities has 8 sites throughout King County, from Enumclaw all the way to Northgate. Within the next 6 months, we'll be opening 2 inpatient facilities. We are opening our inpatient facility in October down on Beacon Hill. And the opioid crisis we know has really hit a lot of people. We are progressively evolving our treatment so that it's providing hope for clients, and we do that through non-judgmental treatment. We understand that the clients that come in, that opiates may not be their only drug that they're using. So we are rapidly moving towards a harm reduction model. That means that clients that come in, we will assess and hopefully reduce the harm that they're doing to themselves. Valley Cities offers, we have medical services in most of our locations. We have mental health services. We have housing services, and we also are offering medication-assisted treatment through Suboxone or Vivitrol. So we offer harm reduction, which may include a group attendance, individual sessions, and skill building based on the client's individual need. We don't think that we don't believe that Suboxone will take the place of traditional SUD treatment, but we do think that providing harm reduction through Suboxone will give people the opportunity to have that moment where they will be able to engage in, engage in traditional treatment, moving towards abstinence. The challenges that we see right now is, one of the challenges that we hear most is that clients use to avoid withdrawal. Right? And so one of our sites that will be opening is down in Pike Place, and they are looking at a low barrier treatment program. So clients that come in will get services that day. Because we all know we need to be able to engage our clients and enroll them in services during that initial visit. Okay. The challenges that we see as providers, first of all, not enough resources. Clients that come in, they're ready for a bed that day. We can't provide that. However, like I said, we will be opening 2 inpatient facilities within the next 6 months. So with that being said, at all 8 of our facilities, Valley Cities does also have Narcan kits. And we are moving towards hopefully eliminating opioid overdoses. Okay. Thank you.
So it's pretty obvious that there is behavioral health and substance abuse on this dais, because it's really impossible to separate those two things in the world today. But I'm Steve Anderson. I'm an emergency medicine doctor from across the street. And maybe you're going to ask, why an ED doc up here? And I'm going to tell you, because if you're going to have a problem with opioids, you're probably going to be on my gurney. If you run out early, if you've overdosed and had that moment where you were just about dead, or if you're trying to seek treatment and don't know where else to go, every single day in my department, I have somebody that falls in those categories looking to me for help. Last night was in Des Moines, Iowa, giving a lecture I give nationally called Dying to Ease the Pain. And if I can, I'll give you that hour lecture in the next 5 minutes. And walk you through this a little bit, because one of the things that bothers me the most, all the statistics you're going to hear, but you have an 8 times greater chance of dying from an opioid overdose if you're a Medicaid patient versus a standard patient. We're taking our most at-risk individuals who have the least voice to speak for themselves and killing them at an 8 times greater rate. And if you go to the ED 5 times in a year, you've got a 48 times greater chance of dying from an opioid. So the ED docs in America have really taken ownership of this entire existence. And it started back around 2000 when we really saw the graph of overdose deaths in America start to go up logarithmically. It was no longer a gradual rise, it was exponential. And we started to do better around 2005 to 2008. But one of the graphs that I show in my lecture is that the only 2 parallel graphs that you find from 2000 to 2010 were the number of prescriptions for opioids and the number of deaths from opioids. So physicians had to take some ownership on this. We were the vectors early on in this whole process. So I'm going to talk about 3 things that we really needed to address, but the first thing is pills on the street. We needed to decrease the amount of opioids that were out there. And we did a lot of different things with, actually, and I'm proud to say, the American College of Emergency Physicians kind of taking the lead on this. We created a prescription drug monitoring program, and if you don't understand what that is, that means every time a doctor considers writing for a prescription for an opioid, he can look up on a website and see how often that's already been written for in the last year. So he can see if 6 other people are writing for this, he can see if you're in a pain management contract, and he can see how many pills you're getting where. The problem with that program is that you have to go what I call 3 clicks to crazy. You got to go through 3 login screens to get there, and if I'm a busy doc, I don't have time to do that. So in the ED in Washington, we've created something that everybody else in the country is trying to do. We push that information to the doc. So I'm not just looking up the 24-year-old tattooed individual I think is playing me. I'm seeing the report on the 32-year-old mother of 2 who I can't understand why I'm negotiating over Percocets while her 2 kids are playing on the floor. So the PDMP is a game changer. But what really helps with that is in Washington State, we're the first state to create something called the Emergency Department Information Exchange, where when you log into an emergency department, I get a readout of how many EDs you've been into in the last year, because if you've been there 5 times, you got a 48 times greater chance of dying. I see why you keep coming back and why we haven't solved your problem. And this EDIE, this Emergency Department Information Exchange, it's not about busting drug seekers. It's about finding coordination of care for people that can't find solutions any other way. And that's why I get called all over the country to find out how we did that. We did some other things in the state of Washington that are now national programs. We created guidelines for writing opioids for chronic pain, because chronic pain is different than acute pain. In the emergency department, I'm a specialist in acute pain. But chronic pain's not my expertise, and we probably shouldn't be managing that in the EDs. We've created what are called ALTO programs, alternative to opiates. Doesn't mean I don't use opiates in the emergency department, but instead of reaching straight for the OxyContin and straight for the morphine, I now start where I should. Tylenol, ibuprofen, physical therapy, lidocaine patches, heat, ice, all those other things before I just reach for a narcotic. And finally, the other way we decrease pill counts on the street is that we've expanded take-back programs. Used to be that the only people that could take drugs back from you were the or the DEA and the Sheriff's Department. Now, every hospital that should have a program, they don't, but they should. Every pharmacy should have a take-back program to take back your leftover drugs, because where do overdose patients get their drugs from? Over 50% of them get them from a friend or a family member. So we're going to talk about your medicine cabinets and cleaning out your medicine cabinets with take-back programs. You know what? Washington's been awesome. We're the only state in the union to decrease overdose deaths from opioids 8 years in a row until this year. And it's not that other states are now decreasing 8 years in a row. We'll come back to talk about our friend heroin and our friend fentanyl and carfentanil and all these new drugs. But we actually are pretty good about getting the pill count off the street. So then what's filled in the gap horribly in Washington State is heroin's resurfaced. It's dirt cheap. It's available everywhere. And now you can find fentanyl and carfentanil, which are 50 and 100 times more potent than heroin. 3 grains of salt of a drug called carfentanil that you can order over the internet from China can be a lethal dose. It's a rhinoceros tranquilizer. And it's now hitting our streets slightly in the state of Washington, but is overwhelming Ohio and some other places. So the pharmacologists out there are trying to stay one step ahead of everything we do. So no matter what we do to try to get the drugs off the street, we need a backup plan. And these people have already been before me talked a little about naloxone. Naloxone is this Lazarus drug. It immediately binds to all the opioid receptors and literally takes a comatose, non-breathing individual to wide awake within a minute of giving it. It's an amazing thing because we can now shoot it up the nose instead of having to pull out needles and find other ways to go. There's even a thing called an auto-injector that will talk you through it by pressing a button. It's like a defibrillator. It'll say, you know, place the patient in this position, call 911, put the auto-injector on their thigh, press the button. The problem with some of these forms like that is that particular drug costs $4,500. A lot of people that need that drug don't have that kind of money. But what we did do in Washington is we made naloxone available over the counter. You don't have to see a doc and get a prescription for it. So I got news for you. Anybody here who's in that 81% who's got a family member that means something to them, I got a suggestion for your Christmas present this year. every single party where somebody might be using an opioid, there ought to be a dose of naloxone in that room. And so we need to get naloxone out there. But once people realize that they're addicted, truly can't get off this stuff, then the problem is, and we had it heard already, you don't wake up every morning wanting to get high. You wake up every morning not wanting to be low. You don't want to go through withdrawal. So we need what's called medical assisted therapy. Drugs that can help bridge you from OxyContin, from heroin, to a clean and sober life. And those things, you'll hear them talked about, Suboxone, buprenorphine, some other drugs, methadone, are out there as options to help bridge this. But they're really hard to find. We're going to hear in a second, there aren't enough providers to go around. It's not cheap. And so I need people to help push for those sort of things as an option too. How did Prince die? Prince, who was anti-drugs. Everybody know Prince? Please tell me you know who Prince was, and I'm not that old. One of the most talented musicians in the world and wealthiest individuals, was against drugs for years, but he jumped off speakers. He ran around stages. He got arthritis in his hips, and he got hooked on opioids by a doctor. He overdosed on his plane. They landed the plane. They found him a dose of naloxone. They saved his life on a Thursday, and he couldn't get his first dose of buprenorphine until Monday. And he had an appointment. There was a guy sitting in his office with his very first dose of buprenorphine, and he didn't show up for the 9 a.m. appointment, and they found him dead in his elevator 1 floor up because they missed their window with that transition, what we call the warm handoff, from the naloxone save to getting on the drug to get off this stuff. So I'm going to turn this over, but I've got asks for you, and I'll tell you them again later on. First off, we need to let our elected officials, like the mayor, who understands this, but they need to hear. We need behavioral health and substance abuse programs. We need medical assisted therapy out there. We need rehab for people. It costs money, and we need to make an effort. And I'm telling you right now, there's something called the AHCA that they're talking about right now in the Senate, which has huge cutbacks in those programs. So please, let your legislators know this is important to us. 2, talk to your doctor about other options. Pain is no fun, but you know what? Not every pain needs an opioid to cure it. So when you talk to somebody, say, what are my other options? 3, clean out your own medicine cabinet. People go to people's houses and go use the restroom, and all of a sudden they're in the medicine cabinets looking around. Use take-back programs. 4th, if you need it, the emergency departments in the state and the emergency department a block from here in Auburn is open 24/7, 365 to help you try and find solutions. Even though they're hard, we're there for you. And finally, like me, you can hate heroin, but never stop loving those people that you care for.
I'm going to stand up, not for any other reason than I won't be able to see what I'm talking about. I sort of feel like Dr. Anderson was the mic drop, and really everything else that we're going to hear today, although Keith's personal story, everything else, really, it's really well capitulated in what we heard earlier. I just want to sort of transition to what I'm going to be talking about with a statement that I heard. So I was honored enough to co-chair our King County Heroin and Opiate Task Force that ended last September, started last May, that your mayor was so key and instrumental in, and your police department was such an active participant in. I'm going to start off with a quote from one of my colleagues the first day. And he goes, "We're not going to be successful countering this epidemic until we make treatment as available as every single drug dealer out there." And that really stuck with me, because if you think about exactly what Dr. Anderson said, when somebody with opioid use disorder, I'm going to call it opioid use disorder, I'm not going to call it addiction, and I'm not going to call people addicts, right? I'm going to call it opioid use disorder because it's people living with an illness, and it's people living with a condition. And so when somebody with opioid use disorder wakes up, the first thing that they want to do is get high. And if it's easier for them to turn to their drug dealer than it is to turn to get treatment or have treatment available to them, then that's what they're going to do, because being sick sucks. Sick sucks. That's making sure that came out right. So anyway, I was getting ready for this presentation this morning, and I was combing through some research, and as we all use Google, right? And I came across this. And this was from this morning, right? In Auburn. And I was like, this is pretty amazing, and I thought I would bring it to you all today. And I don't know how many of you all saw this, but driver who causes fatal motorcycle crash in Auburn may have been on heroin. And I'm not going to speculate. I'm not going to ask our law enforcement to talk about it. I'm just going to say that it's out there, right? And 81% of you, 83% of you, depending on the time you text, know somebody that has been impacted with opiate use disorder, is that struggling with heroin and prescription opiates. You can go to the next slide. But that's what it is, right? So I share with you this picture because this picture means more to me than anything in the world. And I'll talk about it, and I'll be brought to tears every time I talk about it. So over there on the far side from me is my son. He's now 15, but this is when he was 3. And over here is my brother. And this picture was taken, I don't know, maybe about 6, 8 months, so about June 2004. So myself, my brother, my brother-in-law, and my son all went camping. Amazing, right? My son and my brother were so close. At the time, it was my only child, and that was my son's only uncle. And so I fast forward a couple of months to New Year's Day when the phone rings, and we get a phone call. I get a phone call from my dad, and he's like, "Are you sitting down?" I'm like, "Yeah, I'm sitting down." "What's up?" And he goes, "Your brother's dead." And from there on out, life changes, right? Because the one thing you can never do is, at least that we haven't figured out yet, is to reverse death, right? And so life changed that day. We learned a lot about my brother. My brother was a good kid. He wasn't your typical heroin addict, typical, right? But he was a good kid. He was college educated. Him and I went to college together. He was 3 years younger than me. He had a good job, all that type of stuff. He wore it well. But little did we know there were secrets, right? And, you know, that's what substance use disorder does for people. And so trying to tell my son about what happened, and then days to follow, talking to my parents and consoling my parents, and still to this day, 12 years later, trying to console my parents, has been a labor of love. Because I talk about this all the time, and my parents still don't talk about it because of the shame and the guilt and all that type of stuff. I talk about it because coming out here is part of my therapy, right? Because if we can make treatment available and if we can make services available, but if we can really destigmatize and reduce shame, because any of us could be in this type of situation. Next slide, please. So I'm just going to run a little bit of data real quick, give you a little bit of data. So from 2008 to 2012, and I'm sorry I don't have more recent data. This is what I could quickly grab in getting ready for this. This is from Washington State Department of Health. You can see down here number 1, number 2, and that's not because Auburn is 1 and 2. It's just because of how the regions are numbered. But has 2 of the highest rates of overdose death in the county. Okay? So is opiate overdose happening? Yes. Is it happening here? Yes. Is it happening in North King County? Yes. Is it happening in Seattle? Yes. Is it happening all over? Yes. Okay? But I just wanted you to take a little snapshot of where this was in 2012. You can keep going. Okay? So this is a cumulative map of drug-involved deaths. I think this goes up to 2015. This is from, and I'm sorry, I didn't put the dates, but I believe this is all the deaths in the county from 2000 to 2015. But what you can start to see is clusters, and there's definitely clusters in Seattle. That's the red outline up top. But you can start to see, but this is Auburn, right? And so this is our community, right? These are the people that get transported that the police find on the street, that fire is called for, that Dr. Anderson sees in the ED that can't be revived because it's too late, right? And so in order to get to people, we have to do two things. Number one is we have to reduce shame and prejudice, right? In my shop right now, we stop calling it stigma, right? Because we sort of have this philosophy that we need to call it what it is, which is prejudice and discrimination against people who are suffering, right? And we need to be able to provide services. We know that 85, as Dr. Anderson was telling you about, 85% of the people who are in our publicly funded treatment system, which I'm responsible for, are on Medicaid, so they're low income or they have some other type of disability, right? That's prejudice against people who are suffering. You can keep going. So this is a little bit of data too. This goes from 1998 to 2013. But what you can see is a steady, slow trend almost everywhere, except for Seattle, ironically, during that time period, of where overdose deaths happen. And for Seattle, it was so high, that's why it was hard to keep up. But what you can see is all different parts of the county, East King County, North King County, South King County, overdose death rates are up, right? With heroin, with any opiate, and with all drugs. And actually, so to what Dr. Anderson was saying, when you look at some of the trend lines, it's really interesting because from 2000 about to 2012, you saw, or 2009, you saw a huge increase in people dying and entering treatment for prescription drug abuse, right? About 75% of the people that were dying from overdose on pills and stuff like that. And so the doctors took notice and they started to change things, right? And they started to change formularies that made it harder to abuse. And so what happened was in these trend lines, you see trends like this, right? So people dying of prescriptions went down and people dying of heroin went right up, right? I mean, it's pretty clear. You can keep going. This is another slide I wanted to share with you because basically what it tells you, no matter where in the county you live, is that from the time somebody starts using, right, which on average is about 22.5, although we know now that that's probably underreported and people are actually probably starting using prescriptions a lot earlier than that. It takes about 12 years from the time somebody starts using till the time they get into treatment, right? And that's two reasons. That's shame and that's prejudice and stigma, right? That's how people feel about themselves as somebody who's suffering. And that's access to treatment, right? Until we make treatment as available as a drug dealer, then people aren't going to be able to access treatment. We have about 4,000 people countywide on methadone right now, right? And we still have people who are waiting to get into treatment. You can keep going. So I wanted to share this with you. Some of our colleagues that are here from treatment agencies, right? But this is where there is currently methadone with medication-assisted treatment facilities that serve methadone. Take out E and F, right? And the reason I say E and F because up until about 2 years ago, E and F didn't exist. So up until about 2 years ago, anybody who wanted medication-assisted treatment had to drive closest place is Central Seattle to get medication for their substance use disorder. We know that about a year ago, we had 500 people from the South End, including a huge chunk of them from the city of Auburn that were traveling north almost every single day to try to get medication. Right? We've really worked hard to expand treatment. So Evergreen Treatment Services opened a facility in Renton, and they're here today, and they have literature. And Acadia, which was a private for-profit agency, we've entered into contract with them, so they take publicly funds now too. But what I'll say is it's still not enough. We're at capacity countywide, and people still have to travel significant amounts of time. Next slide. So we need to continue to do better and make treatment more accessible. Heroin-involved deaths countywide were the highest they'd ever been in 2014. They've continued to sort of rise slowly, almost plateau, but that's what triggered our task force. Treatment admissions for heroin have doubled since 2010. I can say in 2015 was the first year in our publicly funded treatment system, heroin was the primary drug of choice across boundaries. You can keep going. Oh, there's nothing else. The last thing I'll say is that there's some really good information from the University of Washington Alcohol and Drug Abuse Institute that Really, people need to be able to access any type of treatment they want, right? Whether it's faith-based treatment, whether it's detox, whether it's abstinence-based treatment or medication-assisted treatment. The one thing I'll say is that treatment success rates for people who are not on medication are really bad, right? So we need to destigmatize the idea that medication is substitution. Medication is not substitution. Medication is medication for a disease, right? And so people who are on buprenorphine, Suboxone, methadone have have a 50% chance of cutting their mortality in half. If you ask an oncologist, a cancer doctor, if they had a drug that they can give to their people that would save them 50% of the time, they would be floored, right? And so the more we make treatment available, the better it's going to be. The more avenues we make for people, the better it's going to be. Thank you.
So you've heard some pretty amazing information already tonight, and I want to introduce you to my friend Keith. And Keith, when he walked up on stage, goes, "Oh, you're kidding me. I just want you to know how brave I think you are for being here this evening, for your willingness to share your story." Keith is very, very real, right? He's probably mad at me because I told him, "No, you got to get here. You can't go home and change your clothes. You got to get here." But this is what a real person is, right? You don't have to try and you don't have to try and put a shirt and tie on. This is real. This is raw. And Keith is very, very brave, and I'm proud to call him my friend. And I want you to hear his story because it could be anybody's story. So, Keith, thank you so much for being so brave to be here. I love you, my friend, and I'm going to give you the mic.
I wasn't quite expecting this kind of turnout. My name is Keith. I was 41 years old when I took my first opiate. Started out from depression. I've been very involved in this community. The lights are here. I don't know who I know out here, and that was what just scared me the most, was who was I going to know here. I know my wife's concerned. She's been texting me, very concerned that I'm doing this, but it needs to be done. A so-called friend of mine gave me my first Percocet. He noticed that I wasn't my normal self and said, "Here, let's make it feel better." Okay, yeah, I was pretty busy, needed to do some things, took it. And next thing you know, when I didn't take it, I was hurting. You heard some of these guys talk about the sickness. And that is, quite frankly, one of the worst things that I've ever experienced. I used to see some of this stuff on TV. Why are these pills? Why do people do these pills? I don't understand pills. I don't get it. I got it, and I got it really bad. It was costing me upwards of $600 a day for about 8 months. A lot of money. Fortunately, I was a very highly functioning addict. I had the money, and that was not a good thing, but bills got paid, everything got taken care of. I was very highly functioning, but I was doing what I was doing to not feel sick. As long as I wasn't feeling sick, I could do everything I needed to do. Doing everything I needed to do meant selling my Harleys, selling my RV, selling about 60 pounds of silver. I collected everything. Got rid of most of the stuff I like to have. But that's okay. I came to Nancy one day just because when I decided to get, let me back up, when I decided to get clean, I got clean because I knew I could not afford $600 a day forever. I knew the next thing it was going to be slamming something into my veins, much cheaper. That's what I hear. But I just knew that was going to be that was progression. That's where it was going to be. And I just wasn't going to do it. So October 22nd of last year, I started thinking about, well, what am I going to do? I had a whole week to think about it. I already knew what I was going to do. I was going to work the rest of the week. This way I'd have a full paycheck. And October 29th, I was going to check out. Had everything set. That was it. And it didn't work the way I planned. I didn't plan on being around October 30th. So now I had to figure something else out. Started looking for a place that I can get help right now. Like they said, sometimes the beds are not out there to be found. Found a place in Tacoma. I said, I need to be able to do this now. And I went, And they did. They started me on the Suboxone. They did the induction, got me started right away, and instantly I felt better. I was able to now start working. The Suboxone helps me work on my, without the physical cravings, I could work on my mind and figure out what happened. So that's what I'm doing. I'm doing very well. It's been since October 29th, so about 283 days. But, thank you. During this time, I mean, I've been able to try to reconnect with my family. 2 daughters I still don't really talk to. Sorry. But, like I said, my wife is pretty ticked off that I'm doing this because of, I guess, how this is going to affect her, but it is what it is. It's more than about just her and I. I went to Nancy and said, look, there's nothing here in Auburn. Why do I have to go to Tacoma to do what I got to do? The problem is here. And the biggest reason is because of what a lot of people think an addict is. A lot of people think that an addict is, I don't know. I mean, I know what I used to think an addict was, and we're everywhere. A lot of people say we don't want that in our neighborhood. Well, we're already here. Like I said, for the past 15 years, I've been a very, big volunteer in this community. Auburn Junior Football, Auburn Wrestling, the Miss Auburn Pad, I mean, you name it, I've done it in this community. That's how I met Nancy so many years ago. I had mentioned to my doctor, he was putting on something with the opioid task force. And I'd mentioned to him that Nancy and I were friends, so he'd asked if, I can get her to come, and her and I came with me. Most of the people he saw on a daily basis at his clinic are people who have been addicted all their life. I was kind of like an anomaly to them, and that really bothered me when I first started going, because I'd sit in these rooms, in these groups, and I'd go to group twice a week, and I'd sit there, and at first, when I first started, I was like, I'm not like these people. I don't do meth. I don't shoot needles. I have a job. My kids aren't being taken away from me. I've never been in jail. I've never had to go shoplift or anything, and that's not how I am. So I wouldn't say anything at these groups, and they weren't doing nothing for me because I wasn't saying anything. But I was really afraid that when they came around to me and said, hey, Keith, what's bothering you today? And I'd be like, well, the hot tub guy said the hot tub be installed a week ago and it's not in yet. Then I'd be like, what the hell, you think you got a problem? We have this. So I told that to my doctor, and he said, no, you need to talk about what bothers you, because a lot of people don't have what I have and think that just because, they're where they're at in life, that's why they're an addict, that it doesn't happen to us all. So I was really glad to really start opening up, and, I'm going to a peer counseling thing now to where that's what I'm going to start focusing on, aside from my other job, reaching out to people who just think they don't have hope and think that where they're at in life is the only place they can be. So hopefully we can. I mean, we can do something, get something local and reduce the stigma, because like I said, we're already here. You might not see it, you might not want to see it, but they're here. It's it's very bad. A very good friend of mine just lost his job this week. $140,000 a year is what he was making, and he started stealing from the company and he got fired. So at 30 years old, he's going to start all over. It's his first job he ever had, so it's going to be really hard for him to, what's he put on the resume? They're not going to give him a good, review, so, he hasn't worked till he's 30. So this stuff will take everything from you unless you stop it. And we have to want to stop it, and that's what I talk to so many people that are in these groups, that you have to want to do it. Nobody can force you to do it. I've had some parents at some of these places ask me, well, my son, he says he's going to do this, and we're trying to get him to, we're making him do that. Well, you can't make anybody do anything. We have to want to do it ourselves. It's hard. It really sucks. Like I said, the pain of withdrawals are just awful. The restless leg syndrome, the sleepless nights, the insomnia, that was, you'd think you want to stop on your own, and then you do that for 2 days, and you're like, hell no, I got to use. So we just got to make the services more accessible. Like we said, cheaper. I mean, not, nothing's free, but, just make it more accessible, and, just kind of support. That's one of the biggest things, support, Don't don't turn a lie. If you think something is going on, it probably is. People thought a lot every now and then about me. Are you all right? And I'd always have a long day at work. That. I'd always have something. But if you start suspecting something, don't be shy. Just figure out what's going on, because it will, kill. It almost killed me. I got very lucky that the gun didn't do what it was supposed to do. So I think that's it.
A couple of things, and then we're going to go to the questions that have been brought in, and continue to send in your questions if you have one. But one of the things that really surprised me when I started learning more about this and being more involved in these conversations is that the state of Washington, depending on which survey you look at, we are either 47th or 48th in the nation when it comes to funding behavioral health. We are so woefully underserved that, as you heard, if somebody is ready for treatment, that warm handoff, we don't have it. And somebody comes in and they say, I am ready. I have hit the point where I am ready. And we have to say, great, can you hold on to that and come back in a week? No. They could be dead the next day or later that day, because we don't have the services available to say, yes, you're ready, come with me, we have a program for you, we are so happy to help you, let us be here for you. Now, to me, that's almost criminal, because if somebody wants help, if somebody wants to get out of this, don't you think we should have services available for them? Don't you think we should? Yes. So we do. We need to have those services. And so it's been part of my journey through being mayor is to be one of those voices to try and talk with our legislators, talk with Congress. I've been back and I've spoken with Congress members, our representatives, about what we need to be doing here. We have the heroin and opioid task force, and thank goodness for Brad and for everyone up here on this panel that is involved in trying to make a difference, in trying to remove that stigma or the fact that someone has a substance use disorder. We don't think poorly of someone who has a broken arm and goes in for treatment. We shouldn't think poorly of someone who may have a substance use disorder and goes in for treatment. We shouldn't. So that's something I hope that you will all commit to working on as we leave here later this evening, that you will commit to be one of those voices that goes out and says, we need more funding. We need to quit looking at someone who has an addiction and think we are better than they are. Because you can see from the fact that Keith is here tonight, it's us. There used to be those that had an addiction when it was an addiction. Oh, it's those people. Or I bet just about every one of us has had a vision in our own mind of what an addict looks like, right? It's that gaunt street person. No, it's not. It's our babies, it's our loved ones, it's our friends, and we can't afford to let this happen anymore. That's why, even though it's an uncomfortable conversation, we have to have it. And we will have it, and this is just the first step. So I hope when we leave here tonight, you are all committed to taking those next steps with us. They're not always popular steps. In fact, Brad and I have talked about having a methadone and buprenorphine clinic here in Auburn. Because as he said, and he's told me before, at least 150, if not more, of the people that are seen at the Renton Clinic or the South Seattle Clinic have an Auburn address. So when someone says, oh, if you have a clinic like that, you're just going to attract those people, they are our people, and they are already here. And for those that say we need to take care of our own, which is what South King County has always done, that's part of what it means to take care of our own. But until we can educate enough people so that they're not fearful that we're bringing people into our community, then we have a fight on our hands. And I am willing to take that fight on, because I believe that if we had that clinic here, the clinic in Renton, we went and toured, and I will tell you, I have a doctor in that same building, and I had no clue that Evergreen Treatment Services was providing a methadone and buprenorphine clinic right in that same spot. No clue at all. And they're open from 5:30 in the morning until 11:30, I believe, because they are treating functioning people with substance use disorders. They are going to work. They come in, they get their treatment. Typically, they'll be there for 5 or 10 minutes, and then they're gone. They're on their way, unless it's their turn to have a UA done or they're there for counseling that day. 10 minutes typically, and they're out the door on their way to work, because they've had a treatment that will allow them to continue to function throughout the day. Now, there is no one treatment. I mean, the providers that are here tonight will tell you there is absolutely no one treatment that's right for everybody. So that's why we have different treatments available. For some, being on methadone or buprenorphine is a lifelong journey once they've decided that they no longer want to use. And for some, it's short term, and for some, drugs, an exchange of drugs is not what they want, and it's not what is working for them. But we have to have all of those different options available so that we can get our loved ones the help that they need. Now, there was a mention of a take-back program, and I just want you to know that we have a take-back program located right in our police department. So if you drive by Main Street at our police department, at our Justice Center, just inside the doors, there is a big box. I took a couple of loads of old prescriptions from my house just a couple of weeks ago. It's very easy to do. All they want you to do is scratch out your name on the prescription bottle or on the pack, and you can drop them in that bin, and they will be destroyed. And getting all of those drugs out of your medicine cabinets, out of reach of your child or your loved one, is critical to success. So I want to see that box down at the police department overflowing. Please share that information with all of your friends and family, and get the drugs that are going to harm out of your homes. So the first question, and I will give the microphone over to whoever wants to answer these. So the first question is, does the statewide system identify doctors who have patterns of frequent prescriptions of opioids? Dr. Anderson, I bet that's a great one for you.
Yeah, it's not just the state. The DEA actually tracks physicians and their prescription patterns for opioids. In fact, I'll just give you an example. 80 of the top prescribers of opioids in the nation lived within a 30-mile and practiced within a 30-mile radius of Miami, Florida in 2010. 80 of the top 100. I don't know if you've ever heard of oxytourism. And 8 of the top 9 prescribing pharmacies were within 5 miles of those physicians. And they stepped in. Those are called pill mills. And there is legislation, or there is law in Washington State to prosecute and close pill mills. So we have a process of tracking physicians. We have a process of closing the pill mills. I will tell you, though, that physicians, if you want to change physician behavior, as I tell people, there are 2 ways. One is economically incentivize it, but the second is what we call peer embarrassment. show docs where they fall on the bell curve, and most docs will want to move towards the right direction. But for years, we didn't get the feedback. We had no clue where we ranked. The part of something that we instituted a couple of years ago in the emergency departments was making every doc available or aware of where they ranked in their department on writing prescriptions. And so, yes, there's now feedback, too, for physicians. And I think that does make a difference.
So due to Mayor Backus's leadership, we were able to pass some legislation that was signed into, that the governor signed about a month ago that improved the utility of the prescription drug monitoring program, as the doctor was talking about. So now we have that, we will be able to get that information at the local level where we never were able to get it before, to see what prescriber behavior looks like and to be able to provide feedback and where prescribers are within their percentile. But it's really about improving this functionality of the PDMP now that we can use it to sort of do some more proactive work.
Okay, where in Auburn is a safe site considered for the clinic? So I'm going to assume that you're talking about the methadone and buprenorphine clinic that I mentioned. And we are not sure yet. And clearly it's a very politically charged issue until we have people understanding what that type of a clinic is. So you would typically want them in an area that has other medical uses around, right, Brad? So we're not to the point of identifying that location, but it's a conversation that we need to have. And so tonight was the first opportunity for me to share that with you as just an opening statement of what we could do. Close to public transportation, yes, absolutely. And we will continue those conversations. So that is one of the questions that's in here about a safe injection site. And I will tell you that that was one of the 8 recommendations that came out of the Heroin and Opioid Task Force. I will also share with you that the City of Renton and the City of Auburn were 2 no votes on that. I am all for all different types of treatment, but there was a wonderful story on Como last week that Eric Johnson did. Maybe it's about 2 weeks ago. And it did show the site up in Vancouver. And it showed drug dealers hanging out in front of the location. And police officers, you know what's going on, but yet it's a safe area. I can't wrap my head and my arms, my heart and my mind around having a safe injection site, it's called a community health engagement location, a CHEL. And Brad, I know that is one of the recommendations that came out, and Brad is for, I don't want to put words in your mouth, but Brad is for whatever it's going to take to get people the treatment that they need. But I can't yet. I want to have someone who has a substance use disorder. I don't want them to just be safe. I want them to be recovering, and I want them to be over that. So it's a hard decision, but I will tell you that there is no plan for having a CHEL in Auburn. Regardless of what some of you may have heard, there is no plan for a safe injection site to be located in Auburn. So we are working on getting on-demand treatment. That's the big thing, right? And the fact that one of the recommendations out of the task force was to have naloxone or Narcan more readily available. Just last year, our police and our fire started carrying that. And as you heard, 14, I believe, Did I hear 14 lives have been saved? 14 uses? 14 applications.
You know, it's really interesting. So as all of you clap one way or another, sort of have indicated that this idea of a child or supervised consumption space, the one thing that it's done is stimulate conversation, right? And I've, you know, and it's stimulated conversation, and it's brought people out to have conversation about how we need more treatment. And really that's, you know, why we're here tonight, is to say that people need more treatment. And so whether you have a child or don't have a child, if you don't have treatment available for people, they can't access their way out into a meaningful life. And so whether that's abstinence-based treatment, whether that's faith-based treatment, whether that's medication-assisted treatment, until we have medication-assisted treatment on demand, we're never going to be able to work our way out of this problem. So, you know, for the love of the child conversation, it sort of polarized everyone to say, we need more help, right? And that's why you all are here today. 80% of you that are here today, and I won't even say in the audience because I filled it out too, have been touched by somebody with opiate use disorder. And so no matter how you feel about that, the idea about supervised consumption, the fact of the matter is people need help, right? And we need to be able to access help, and people need to be able to get help, like the mayor said and like Keith said, when people need it.
And as far as like 12 years, we can't let anything go 12 years. I went from 0 to 60 and back to where I'm at now, and it's been about 19 months. So I went from never doing anything to getting full-blown addicted, losing everything, to being where I'm sitting now, and it's been about 19 months. So we just can't let people wait. If you see it, like I said, just do something. Don't let it go, because 12 years is way too long.
So we are, for those of you that may not be aware, we are working in partnership with Valley Cities to open an overnight shelter and day center on Valley City's property, and there will be wraparound services available there. That's what we're doing until we can find a more permanent solution. This is a temporary up to 2 years where we will have access to treatment available, or counseling at least, until we can get that on-demand access to treatment that we're talking about. It's a Band-Aid, it's a baby step, but I'm proud to say that we are going to be opening that shelter with Valley Cities in just the next couple of weeks. Yes?
And there's lots of programs out here that are there to help. Look into them. Nexus, which used to be called Auburn Youth Services, has a building that's got a floor space of maybe 300 square feet where kids in need can go at night and have a safe environment and get a shower. You'd be surprised, getting a shower is a huge challenge to people in this environment. So there are lots of services out there that are trying to fill that void. But if you want to look at components that actually change social health, having a safe place to sleep at night is one of the top priorities.
Right, it is the most important thing. If you have shelter over your head and food in your stomach, then it's easier to focus on those other issues and those demons that you're battling. And something to do, yes. So at the shelter and the day center that we are going to be partnering with, there will be people there to help with jobs, with training, counseling, and other treatment programs. So we are really proud that we are down this path, and hopefully we'll be able to tell you that we have been very successful with this. And I hope that those of you in the audience don't think that if we build it, they will come. Right? That's a fear-mongering way of thinking about this. We have to help those in our community. And that's what this day center and overnight shelter will be doing, similar to if we were able to get a methadone and buprenorphine clinic in our city at some point. What are those next steps that you're talking about taking? So I think I just kind of answered some of that, but it's also going to be about legislation. And I am on the South Sound Behavioral Health Coalition, which is a partnership with Multicare and CHI Franciscan. Now, typically you wouldn't have two competitors partnering on something, but in this case, they are partnering to site a behavioral health clinic or hospital on the Allen Moore site in Tacoma, a 125-bed facility. So I am part of that coalition, going around finding funding. We went to the Milgard Foundation, and they provided $1 million. It's a $40 million project, and the healthcare providers have guaranteed $5 million each, or $10 million each, sorry. And we have state funding available for about $7 or $8 million. But we're going around to the local cities and to the counties asking for contributions as well. Now, 125 beds, I thought, that's not really a lot. But when you consider the average stay is, well, it would be a maximum of 14 days. That's over 5,000 people that we would be able to help in just that one hospital. So while we don't have all the funding yet, there will be groundbreaking, I believe, this year. They've cleared off the pad at Allen Moore over in Tacoma where it's going to be built, and I can't wait to be there for the groundbreaking of that, because while it's still not enough, it is a start, and it's a good start. Can't we love the people in our community until they can love themselves? Yes, yes, we can. And I think the fact that you're here tonight proves that. How do you feel about mandating inpatient treatment as opposed to incarceration? So there are some, and I am among them, that will say our jails and our hospitals are the most expensive treatment facilities that there are. But I'm going to let others talk about that, because our jails and our EDs are not the place where we should be providing these services on a regular basis, and jail is the worst place to do it.
So 80% of our mental health beds in America are in our jails. The number one distribution site for Suboxone, buprenorphine in America is from jail cell to jail cell. That's where we put people because, as you've already alluded, we're 48 out of 50 states for inpatient care in America for mental health issues. I feel very, very strongly, as you do, this is an illness. This is not, now it may drive people to do bad things, but we have to address the illness, and incarceration's not the answer.
Yeah, that's a great point. I mean, and I've spent a lot of my career working in institutions, and it's really just a shame how, you know, it's a warehouse of people who are really suffering with substance use disorder, with mental illness, and there's no help. And so we're working with Department of Corrections on pre-release programs right now. There's the drug court program, but it's still, the more we can move upstream, the better off we're going to be, right? And so if we can provide treatment and instead of incarceration, because the truth of the matter is, I mean, I've spent a lot of time working in jails and prisons, and it sounds like you probably, you know, have a viewpoint on it too, is that people get re-traumatized, man, and it's worse for people, right? And so the only thing that ends up, I got a great story. I'll tell it. It'll take 2 seconds. I was working with somebody. They were they suffered from alcohol use disorder, the alcoholism. Judge sentenced him to a weekend in jail. He was coming to me for counseling and therapy, and when I was a therapist in my past life, I was like, all right, dude, let's make this a good weekend in jail. You're going to think about it, come back out better off, right? So he comes out Monday, and I'm like, all right, dude, how was your weekend in jail? Did you learn something? And he's like, yeah, I learned how to make meth. Right? And so, I mean, really, you send somebody into an incarcerated setting and with no help, with no treatment, with no focus, and they're not going to do any better, right? Until they're surrounded by an area of recovery and community. One of the things that we know is that people find recovery when they're connected to a community, right? You know, Keith's story, I mean, we hear it time and time and time again. And, you know, I mean, I'm going to imagine that's part of a battlefield addiction. I'm super excited to learn about what y'all are doing. But, you know, I mean, it's when people are connected to community and they find a place that they can call home and not be ashamed of who they are and what they are, then they're going to feel okay. I wasn't comfortable even talking about my brother's story until I heard my boss talk about his story and know that it was okay, right? And know that it's okay. And, you know, and Keith being able to get up here and tell a story today and have a standing ovation, right? That's community, right? And in Auburn and in King County, we are community. And if we can provide for each other, somebody said love each other until they can love themselves. I would say people try to love themselves and maybe their illness is hurting them, right? And so until we can provide that sense of community outside of incarceration and in other all types of alternatives and treatment, then that's when we're going to be successful.
I will proudly tell you that at our SCORE jail facility, South County Corrections, there is a program now with Evergreen Treatment Services where they are treating customers or clients of SCORE while they are there and extending that treatment after they leave. So baby steps, as I said. We're not going to solve this overnight, but I am really proud because Auburn is a member of SCORE that there are options available now for those who are incarcerated. So again, we will keep working on those things. That's a very good question. How do you deal with the person who really does have the pain? Now, if it's chronic pain, I think Dr. Anderson will tell you it's a different form of treatment. But Dr. Anderson, do you want to respond to that?
We try to do this in an organized fashion. The problem that we're talking about with chronic pain, which is a very real diagnosis, is that we don't find solutions to it that work moving forward. The best example I can give is last year they closed the Seattle Pain Clinic, which was the largest serving pain management clinic in the state of Washington, with 1 day's notice. And the state's website that said, if you happen to be here, try this, 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 and then the last line was, or go to the emergency department. Yeah, and so there is a very definite segment of society that has legitimate chronic pain that seeks a solution that works for them so that they can get up every morning, go to work, do the things they need to do, and function. And the problem is there are limited doctors available in clinics for them. Now in Auburn, I can speak for Multicare, where I work across the street. They have a clinic, but it's hard to get into, and it requires a physician to refer you in. And if for some reason you don't bond, then you're looking at downtown Seattle, downtown Tacoma, and those are limited. So there is a very limited thing. But I will tell you that I can only speak for the state of Washington. What they're trying to do is drive people with chronic pain to one provider and one clinic along those lines, so that they are making sure that there's one person supervising their care, they're getting prescriptions from one provider, filling them at one pharmacy, and so there's somebody who's actually taking ownership and caring about this. Because where we're seeing the problem is people that have 7 prescriptions from 6 different providers, etc., and there's no coordination of that care. But I'm thrilled that you brought this up, because there is a part of society that's found a solution to their chronic pain, but they have to find providers that'll care for them in that segment, and it's a limited number. So chronic pain is a legitimate, in and of itself, diagnosis. I'm very frustrated if you came back to my ED every week looking for treatment for your lung cancer, because I'm not the doc to treat your lung cancer. Physicians, by their nature, want to take care of things that they can heal. I mean, it's why we became doctors. This is not a defense of physicians, but physicians are frustrated when they're confronted with something that they don't have a solution towards, except here's more opioids that I know are now the #1 cause of accidental death in America. I'm possibly putting more pills on the street. So I'm just getting back to what you said. First of all, you're blessed. You have one physician who's trained in the specialty, who's willing to watch over you and willing to help you through that. Because the other thing about addiction, and I'm sorry, call it what you want, And rehabilitation is just like emphysema patients have bad days, they have to go to the emergency department because they can't breathe. And diabetics have days when they have high blood sugars and they need to go to the emergency department because their blood sugar's high. There are people who have addictions who fall off the wagon. They're not a bad person. They're somebody that's coming back for more help, and we need to not label them as drug seekers. We need to be upfront and honest. I'm not here to negotiate Percocets with you. I'm here to find you a solution for your pain and your problem today. And I think when physicians take that attitude, I think that it's light years ahead of moving the conversation of how do I help you.
The next question that I was going to take here and ask Angie to come up, if you would, is what is battlefield addiction?
Thanks for the opportunity. So Battlefield Addiction is an organization where we work through the family. We have a network of service and providers that we network with to help get these kids into treatment quickly, to move fast. We stand on the platform that addiction is a conversation starter. It is the conversation that is necessary to begin the process of understanding that there's a disconnect in the family. And it's also a disconnect in the community. And so what we do is we work with families and through families. And we believe that there is something the families can do. We don't wait for our kids to choose recovery. We don't wait for them to hit rock bottom, because we're dealing with heroin, which is a different demographic than old school addiction. Heroin leads to death, and we don't have time for them to hit their bottom. And so what we do is teach families the right moves to make. We do solution groups up in Federal Way every Tuesday. We're moving up into Snohomish County now on Thursdays. So we do a lot of very important work. And all these people in the first 5 rows or so, we've got recovering girls and guys. We've got family members. We're doing really, really important work. And if you are a loved one of someone struggling with addiction, we are here for you. And we have solutions. And we have been growing this team in a room slowly, one family at a time, for the past 3 years. And now we're ready to go into the community and do the same thing. We believe we can make a huge difference, and we are.
Oh, the website.
Yeah, battlefieldaddiction.com. You can find us on Facebook as well.
Let me just find one more here. What is the percentage of folks that go through treatment are successful in kicking the addiction? Dr. Anderson, do you?
I mean, it's the one person you save that makes all the difference in the world. That said, addiction rehabilitation services are springing up everywhere, and a lot of them are for profit. I believe the last national statistic I saw was something in the neighborhood of about 18%. But that's because a lot of the inpatient treatments that people go through are then not connected to the outpatient other things that they need, the counseling that goes along with it, the reinforcement and the buddies. I mean, organizations like NA are critical to this whole discussion. You've got to do more than just send somebody a place for 2 weeks and say we've cured you.
There has to be a pipeline for when you're done. And treatment services, did you want to talk about after?
I did. So when we talk about sending someone to inpatient, they might get that 28 days. Where they're abstinent for 28 days, we get them through withdrawal. They get out of inpatient. If there's not a warm handoff and they're not connected with outpatient services to help build the skills that they started in inpatient and to help follow through. You know, I understand that we're all looking for treatment on demand. That's what we keep hearing, treatment on demand. We just have to keep pushing forward with it, because if we don't, you know, we're losing.
Sorry, I didn't plan on this. It just seemed like good timing. So the Auburn School District is in partnership with King County, and we got a grant for creating a coalition to prevent the use and abuse of drugs and alcohol by teens. And so we've done the surveys in the community to see what the concerns are. I think that some of the information that troubled me tonight was, average first use is 22, but kids don't wake up at 22 and just say, I'm going to try heroin today. It starts in high school, and it starts with alcohol and marijuana and other gateway drugs. And so we're trying to do what we can to educate parents, to educate kids about the risks that if they start these kinds of behaviors, what it's going to lead to in the future. But we're a brand new coalition, barely a year old. And so if anybody is interested, I don't quite know, come to Auburn High School next Friday, 11:30 to 1. We're having a key leader event where we want to get out more information to how you guys can partner with us.
We'll end it now, but panel, let's give a round of applause to the people in the audience for their willingness to be here tonight. And now let's give a huge round of applause to our panelists tonight. And thank you so much for being here to be part of the conversation. We've just skimmed the surface. We'll do more of these, but thank you for your willingness to be part of the conversation and part of the solution. Thank you so much. Good night.